Injuries of the hand and wrist in sports. So if you look at these old pictures, you can see boxer's fracture, gamekeeper's thumb, skier's thumb, jersey finger or a broken wrist in football. Objectives, well, let's hope you learn a little anatomy, symptoms, signs of possible things that are going wrong, and more importantly, what to do with them and where to send them. That means you ran. So that's a hand, thumb, fingers, metacarpals, phalanges, radius, ulna. Everyone hopefully knows this, but if not, get a picture instead of a bunch of words. It's a lot easier to figure it out. Here, if you want to think about the marbles in your hand, the carpus or the carpal bones, and there's this, some late trainers practically taped Tommy's clean hand to describe scaphoid, lunate, triquetral, pisiform, trapezium trapezoid, capitate, hamate. Or if you watched ER back when ER was on, some lovers try positions that they can't handle. I mean, you go with what works. If you can remember this, I guess you're a trainer, but I remember the other thing. So again, you've got 5 metacarpals, 14 phalanges. The thumb only has 2 phalanges, so there's a distal and proximal. There's no middle. And then you've got the most common broken, mostly people who throw a punch. And if you're a true boxer, you're going to throw leading with basically the MCP joints of these 2 fingers. And if you don't know what you're doing, then you're going to lead with the small finger, and you have a boxer's fracture of the small finger. Muscles in the hand and wrist. Oh, God, this is all so boring. Ligaments in the hand and wrist. There's like thousands of them. Injuries. So these are things that we're going to talk about. Wrist sprains, gamekeeper's or skier's thumb. You've got collateral ligament sprains of the fingers, dislocated fingers, tendonitis, mallet finger, jersey finger, Boutonniere deformity, colles fracture, scaphoid fracture, boxer's fracture. So basically, if you want to prevent wrist injuries, use protective equipment, braces, tape, gloves, padding, but you have to be aware of the rules of the sport. You can't load someone up in a plaster club and send them out on a football field with basically a weapon, unless you're in Texas. But you have to know the rules of the sport, and then based on that, the trainers and your physicians will get the player in the right apparatus to protect them either from an injury or with an injury. So hand and wrist ligament injuries. Sprains of the wrist are common from overuse, falling, twisting motion. You'll notice pain, decreased range of motion possibly, decreased grip strength, swelling. You generally want to treat this with protection, rest. You want to ice, compression, elevate, all of the standard things. Reestablish range of motion and strength. This is important in every joint, but exceptionally important in elbow, fingers, and wrist. If you take an elbow and there's nothing wrong with it, I mean there's nothing wrong with it, and you put it in a cast for a month, that patient's going to lose 15 degrees of terminal extension, period, just from being in a cast, because that's where the body wants it. You've got them at 90 degrees, you take off the cast, body wants to keep them at 90 degrees. You lose 15 degrees of terminal extension. Put them in a cast even longer, they're going to have even more loss of motion. Bye, Adam. So when someone has a wrist injury and you're rehabbing the wrist, you got to pay attention to everything around them. You got to pay attention to the thumb and the fingers. We'll see someone who has a torn ligament in the index finger, And by the time the index finger heals, the finger on each side of it doesn't bend anymore. And their finger that they injured works fine, but they really didn't pay any attention to the fingers around it. And again, if you keep them out straight and you don't move them, you lose them. The old adage is true. You don't move it, you lose it. So you've got to be very mindful about that when you've got people with injuries, especially in the upper extremity. So Gamekeeper's thumb or skier's thumb, used to be called Gamekeeper's thumb, injury to the ulnar collateral ligament of the thumb, right here. Where am I? Yep, right there. So it's an old term used to describe an injury to the thumb when they were breaking necks of rabbits. They would literally take the rabbit in one hand and the other, take the neck, and then they would break it. And that stress on the thumb, you do it enough times and you're going to weaken it, and then it'll just go on you. So that's why it was called Gamekeeper's thumb originally. More recently, we sort of changed it to skier's thumb because there's not quite as many people around the country breaking rabbits' necks. Although with all the shows on TV down here in Louisiana, it's actually not true. So Gamekeeper's thumb, thumb's injured, forcible abduction like baseball or basketball. You're catching it, catches the tip of the thumb. You've got your stress and it pops your ligament. It can be from a fall or a direct impact to the tip of the thumb. So people think they jam their thumb. I mean, there's no such thing. You jam your finger. You jam your finger or you jam your thumb. What you're describing is an axial load to a long appendage. It's not jammed. It's not like you took a can of beer and crushed it. You didn't jam it. You have an axial load and the stress had to go somewhere. Now, whether it went out of the sides through a collateral ligament, it went out through the top through the extensor mechanism, or it went through the ulnar collateral ligament in the thumb. You know, you don't just pull it out and you go on. The only thing you sort of pull out is if something is dislocated. So it's actually, you've torn a ligament or a volar plate, and instead of having a bone being on top of the other, it's out and down, so you can literally pull that out. We'll get to that. But this whole I jammed my finger thing, I mean, it describes an axial load, but it's just way more than that. So if you look at it from a skiing point of view, it occurs when you kind of fall on your ski pole. Ski pole's wedged in your hand, and you have this valgus stress, or the stress is in this manner here. So this comes out this way, and you blow through that. This is what usually your high school or your junior high school athletes will come in, and we always x-ray. They say their thumb hurts right here, MCP joint of the thumb. We get an x-ray because, well, if it was my thumb, it would just tear through the sloppy ligament that has no more integrity. If they're young and healthy, and chances are that ligament's so strong, it will pull bone off, the ligament will be intact. So we get an x-ray and we look at this and we see this avulsion fracture. So this chunk of bone still has ligament attached, and it is pulled right off of their articular surface right here. So sometimes you can just leave that where that is, put them in a splint or a cast, or a splint then a cast, or a cast, and it will heal bone to bone, or fibrous healing from bone to bone. But of course, in this case, when you've got a significant portion of the articular cartilage, you don't have that nice smooth round surface. Then you're really looking at like post-traumatic arthritis later in life. And as much as we want to get them on the football field in 3 days, we might not be able to, because we want to get that joint back where it's supposed to be, so that when they're 30, they can go out and play tennis and they're not crippled in pain from the thumb. So we have to be careful with these kinds of injuries. Here, if you do on a physical exam, basically you're grabbing the proximal phalanx and the metacarpal, and you're applying a stress away from that ligament. And if it is stable, you'll feel a nice end point. I mean, if you just grab your thumb and do this, it just stops. If that ligament is torn, you can spin that thumb right around. It's kind of interesting. But you'll notice no end point. It just kind of keeps going. Then they tell you to stop because it hurts. So, the other thing that we look for in this, I know it's a lot of stuff about one thing, and I realize it's just a hand, but it's a very common injury. It can be very debilitating if not treated properly. The other thing we look for, other than the bone actually being pulled off, is we look for something called a Stener lesion. So when we send a patient to I pretty much send everyone for an MRI, unless I see a big chunk of bone that's not where it belongs with the tendon and with the ligament attached to it. I send them for an MRI because I want to know, does the patient have a Stener lesion, and what is that? Well, you've got this abductor aponeurosis. You've got this is tissue sitting on top of the collateral ligament. The ulnar collateral ligament is underneath this, okay? So you got collateral ligament here, and you've got this aponeurosis sitting over it. Well, if you take this thumb, okay, and you bend it far enough this way, this guy, which was up in here attached to the bone, will tear, and everything's like a rubber band. Everything is under this tension. Well, your thumb goes this way, this will tear and it'll pop back and it flops over on top, or it gets stuck over here. It belongs under here, attached to where the bone was. Well, if they don't have a Stener lesion and they don't have an avulsion fracture, in theory, you can splint them and cast them, and eventually you'll get scarring back down and you can avoid surgery. If you have an MRI and it shows a Stener lesion, like it or not, it's an absolute indication for surgery. It ain't never going to heal because it's just not even in the same zip code anymore. So we have to make an incision down the side. We go through the aponeurosis. We take a suture anchor, which is like an anchor that you just put in the drywall to hang a picture. It's got suture on it, and you attach that right back to the bone, close the aponeurosis, close the skin, immobilize them for 3-4 weeks, and then send them over to the therapist to get that thumb moving. And you have a really good outcome. And pretty much they've all had really good outcomes. So it's common. It's common. Female athletes, male athletes, football players, basketball players. Again, you go out, think about catching a basketball that's thrown real hard, you catch it right at the tip, or a baseball, you catch it right at the tip of your finger. You're a pitcher and you throw your hand out and that ball just catches the tip of your finger. Anyway, so splint, ice, x-ray, look for avulsion fracture, look for the Stener lesion, generally requires surgery. Again, here, this is where it's sort of if you're lucky enough to have a chunk of ligament here, and then you can just sew them back together, sew it over. It's good stuff. So here is an IP, interphalangeal. So we're looking at the joints between phalanges. So you got the little one up here, the distal, the DIP and the PIP and your MCP joint. So you've got these collateral ligaments. They keep your finger they go this way, nice. They're not supposed to go this way. If they do, then you've got a collateral ligament injury. So again, the ligaments attached to the side of the IP joints, one on each side, provide stability when they're stressed. Mechanism of injury, again, ball to the tip of the finger. Or you get the finger caught in a jersey or a face mask. So these things they afford stability in the medial and lateral direction, but if you stress them, they'll tear just like anything else. So what do you do with them? Well, if you have a true tear of the collateral ligament, one of the first things everyone notices, especially if kids don't really notice it as much because they don't really care, but if the 30-year-old guy or the 30-year-old girl looks at their joint and they say, is my knuckle always going to be this size? It's my ring finger and I can't get my wedding ring, back on it. And the truth is, it's never going to be normal. You're always going to have scar tissue. You're always going to have some swelling. You've altered that mechanism in there. It's all nice and streamlined. It's not anymore. So yeah, usually, depending on how much swelling you had, probably it decreases by about anywhere between 50 to 70% will get better, but you're always left with this 20 to 30% bigger knuckle. So you always want to get an X-ray to rule out fractures. If you've got a fracture, obviously you're going to have to immobilize it or operate on it depending on if the joint surface is involved or not. You want to ice them. Get them iced right away. Get them elevated right away. Pretty much any injury in the upper extremity. Get it iced, get it elevated, get it immobilized, and then get them in to see somebody. You splint them when they're not playing. Buddy taping it works really well. Okay? But it's not the ultimate long-term answer for treatment. But if you have a torn ligament or if you have an avulsion fracture and you get it fixed, then you can get them back sooner by using buddy taping because you're affording stability to the finger that, putting them in a splint and then they have no motion of the finger. One, you can't play as well, and two, you're almost doing more harm than good because these joints, you want to move them as early as possible when you can move them safely. So if you look at just what is underneath the skin in a finger, there are just so many structures, and all they really want to do is either move or just scar down to each other. So if you don't get them moving, keep them moving, they just all scar into a big blob. That's the medical term for it. So dislocations, whether it's dorsal or the other side, it's volar. It can occur in sports. See it a lot in football, basketball, fall on the floor, ball to the tip. Someone's grabbing your finger, wrestling, any of those things. You've got, if you end up with a finger and you've got one bone here and another bone next to it, on top of it, under it, or beside it, you have to have something torn in there. So just pulling it out straight and being on your way probably isn't going to be the way to go, because you've got collateral ligaments on the volar side of the finger. You've got this thick tissue called the volar plate. You've got extensor mechanism in the back. You've got flexor tendons on the volar side. I mean, these joints are just surrounded with stuff that keeps a bone on top of the bone. So like you're, balancing a stack of quarters on each other. Okay, so if you think about two stacks of quarters balanced on each other and what you would have to sort of build around that to keep that stable, there's a lot of stuff in there. And if you end up like that, then something, or more than just something, is torn. You end up with damage to nerves, tendons, blood vessels, all of these things. The joint itself. And if you don't reduce these properly, you can get, permanent damage to these structures. So again, get them iced, get them immobilized, and get them in to see us. So, more examples. Always fun to look at. Thumb, and here you've got so your volar plate is right here. And it used to be right there. So if you've got something that's literally 4 millimeters thick and is like as strong as plastic, and it is right here, and if this was there, it would be right here, and it's all attached. If this bone ends up here, you really tore right through that, and we need to do something about that, because you need to afford stability back to that finger, but then you've got to get them, you got to get them to the therapists so that they can. A great therapist can take a mediocre surgery and make it wonderful, and a bad therapist can take an outstanding surgery and just turn it to crap. Remember that, okay? I said the good one first, though. So, since I'm a mediocre surgeon, I try to surround myself with excellent therapists. So, treatment, blah, blah. Tendon, poor boo-boo little boy. So, tendonitis, inflammation of the tendon. Anything itis, inflammation. Epicondylitis, inflammation of the epicondyle. Never mind, that's a different thing. Overuse, stretching, impact. A lot of times we'll see someone who they fell, they think they broke the wrist, everything is just sore as hell, the wrist is swollen, ungodly, and you do an x-ray and there's just nothing broken. You look at the scaphoid and you do an MRI and all you see, all this fluid around all these tendons. Back of the wrist, extensor tendons, there's 6 dorsal compartments. They're very confined, very specific compartments. Each compartment has a very specific tendon in them, and everybody's the same. And if you fall, just the load of the fall, catching yourself, that stress on the tendon can cause those tendons to just secrete all this synovium. And then they try moving them, and it just, now you're in a tight compartment, it's even tighter, and then they're moving it, and it just feeds on itself. So if you have someone with Dequervain's tendonitis, a stenosing tenosynovitis of the first dorsal compartment, basically the thumb. So you've got a newborn baby and a mother who's always picking up the baby, so she's this motion, and you're extending and abducting that thumb, and they come in and the wrist is swollen and painful. It's tendonitis, and you've got to cool it down. You've got to mobilize them. Maybe they need a steroid injection. Very few and very infrequent, please, because you can do a lot of damage with steroid injections in joints and tendon spaces, multiple in a short period of time. You can buy a nicer car, but you can really hurt someone because you'll just turn everything to mush. All right, so ice, elevation, immobilize them, and it's sort of a fine line. You want to immobilize, but you want to get them moving, okay? Rheumatoids, they come in, and they just, luckily, they have all of these new biologic medicines for rheumatoids because it's cut down hand surgery 70% with these biologics. And the patients that do come in that are rheumatoid, I know this isn't sports, they're usually the ones that can't tolerate the rheumatoid medicine. So just as a population, if you have a family member and they're rheumatoid, get them to a rheumatologist and get them on the new medicines because they really work wonderfully. Anyway, rest, ice, immobilize, then get them moving, then strengthening. Tendonitis. Mallet finger. This is just so common, and it is treated so commonly wrong that, and I go through this talk every time, and I hope to never see another mallet finger come into my office where they say, I went to my primary medical doctor and he put me in a splint and it was a month ago, and I'm like, great, so let's see, your mallet finger, which is the avulsion fracture, not avulsion fracture, you blow the tendon, the extensor tendon, right at the distal phalanx, right at the terminal portion. And what happens is you get a droop to the finger, like right here, okay? So the ball hits, and you're trying to extend, and the ball wants to flex, so the tendon ruptures right here. Well, it's the only tendon you've got to extend that. You only got one in the back of the finger. You got two to flex on this side. You blow the very tip of it, and you're going to have a droop. So we put them in a splint. You just splint them for 30 days, right away, every minute of the day. And I get patients coming in after a month of being in the splint, and they're like, well, it's been a month, and I don't know, their fingers like this. And I'm like, but usually it works. Tell me what you've been doing. Well, I wear the splint, and every day at noon I take it off, and I wash my finger, and I squeeze a ball. I'm like, oh Christ. And who told you that? And they're like, well, my primary care doctor told me. I'm like, oh, what's his phone number? So every minute of the day, and I mean, you can take the splint off every day. You lay your finger on a hard table, and you scrape off the little piece of tape in the back, and you slide that thing off, and then you can wash it up a little bit, little alcohol, whatever you want to do, and then you slide that splint back on, and then you hold it, and your husband or wife, they put a little piece of tape on it, and there you go. And you do that for 30 straight days, because if you don't, every time that you flex that finger within 30 days, you are tearing apart the scar tissue that formed, and you're starting back at day 0 all over again. So the guys that come in and say, I did this for 6 weeks, I'm like, great, so let's start over. It's day 0 right now. And they're like, oh, you got to be kidding me. I mean, is there surgery for this? Yes, there is. Do I do it? Very rarely. The thumb, yes. The fingers, almost never. One of the people that trained me said, sometimes the best outcome you can hope for is that the patient gets an osteomyelitis in the fingertip and you have to cut it off. So, that never sat well for wanting to just be real aggressive with surgery. One thing you can do, though, and still, everything in surgery is a risk of an infection, especially who does it. You get the finger out straight and you just slam a K-wire right down the joint. So you've got your splint and you can't take it off. But, you got a piece of wire sticking out of your finger, it can catch on everything. But that's about as aggressive as I would be for a mallet finger, because if you think about it, if you can wear a splint and get the finger back to maybe a 10-degree droop, it's barely imperceptible, who cares? Because what does your finger do? If you can reach out, I can't do it anyway, that doesn't look perverted, but if you reach out, you want to grasp something. That's what your fingers do. So as long as you can get the finger out to grasp, the finger works. The most important thing is it does this. And that's got nothing to do with this. This is just simply getting the finger out. People just don't like the way it looks. Oh, it's got a little droop. Oh, I'm sorry. So you've got the tear, there's the droop. Nah, that's bad. If you work a keyboard all day long and you've got, a 70 degree droop of your index finger, let's say, yeah, it affects your job and it affects your life. All of that's important. So let's get it in the splint. Let's do it the right way. Get it to 10 degrees, 5 degrees, 0 degrees, and we can work with it. If you absolutely, positively want the surgery and everything else fails and you have a droop that does affect what you do, yeah, we can do it, but it can go to crap too, and it's just not good. Anyway, ice, splint, physician, yada. So these are what the splints look like. This is a stacked splint. Most commonly we use this. They come in different sizes. You stick the finger in there, and then the tape goes around here. It holds the finger at about 0 degrees, maybe 2 degrees of hyperextension. You don't want to do the over hyperextension deal. This guy right here, it's a little too much. I'd prefer that to be just a little flatter. And if you do the stack splint, I mean, this is all little just pearls. Use paper tape, because it's easier for the patient to be able to just scrape that tape off, to change it properly every day, instead of having to work with this silk tape that you just can. Then they start taking knives at their fingers. Oh God, it's a nightmare. It's more surgeries, but it's a nightmare. Surgery, here, absolute indication is if you have a bony mallet finger. So a mallet where, again, you're young and you're healthy, God bless you, and you're probably also thin, and your tendon is still there, but it pulls off a huge chunk of bone. That's surgery. I had a kid, was 15, avulsion fracture, pulled the thing right off. We had to go in there, little dental pick, little teeny screw, 1 millimeter. X-ray just hates that. And it fit like a puzzle piece, and it was great. And he went to bed, and 3 days later, he tore it all to hell. And we had to do it again. And it came out great, and the guy's father comes in 2 months later, same exact thing. He didn't want surgery. Splint, the bone was close enough, and it healed. Interesting story to me, not so much to you apparently. Jersey finger. So, jersey finger. You're playing rugby. Used to be called rugger jersey finger. You play football, or you're pissed at your sister. She's running that way, and you grab her shirt, and she keeps going, and you're trying to pull, and the tendon says you win. All right, so you tear the tendon, the flexor, so the mallet's in the back, the flexor, the jersey's in the volar side, the palm side. In sports, again, usually when an opponent's jersey is being held, clenched finger, forced to extend, tears the tendon. Sometimes there's, again, a bony component to this. So here you've got, different... you're just hanging on for dear life. And so this is how they present. You've got your hand and you've got the finger. This guy doesn't flex. It might flex here because you've got your FDS, flexor digitorum superficialis, which attaches here, but you no longer have the flexor digitorum profundus, which attaches here. So this guy is no longer attached up here. So it could tear off here, get stuck here, here, or it can just wad up into the palm, which is here. If you see something like this, if you look at the literature, if I don't have him in the OR in 10 days, his chance of having a good to excellent outcome go in the crapper. Okay? 10 days. Because this tendon down here in a ball, the minute it happens, a tendon wants to have load. It wants to have a load on it all the time. And the minute you take the load off, it goes through its own pathology. It will change the internal characteristics of the tendon itself. It will shorten, and it doesn't even know that it needs to be there to do anything. So we want to get them in the operating room right away. If they don't, what if I wait too long? Well, this is what happens when you wait too long. This here is what the flexor digitorum profundus tendon looks like sitting in the palm of your hand. It's got a chiasm. It's got a split in the middle because that's where the profundus is going to come out and attach to the distal phalanx. So this is what happens. This thing was scarred to here. It's supposed to be attached here. The red, white, and blue is actually the way it looked. It was a very patriotic day. I don't know why, but it really looked like that. But that's the profundus here. And you're trying to get this to here. It's not going to happen. So what do you have to do? Well, you got to do some horrific thing like this. You have to actually take out one of the tendons that you're not going to use, which is the profundus, and then you're going to have to reattach the profundus back to the bone, and then you're going to have to weave that tendon literally through the other tendon, a Pulver-Taft weave, to get these tendons to hold resistance, because he went to the emergency room and they stitched him up and they said, you got to follow up. And he said, okay. And a year and a half later, he did. Boutonniere deformity. Boutonniere deformity, everyone, again, this is like Mallet, where everyone, they have this injury and I want surgery, I want surgery, I want surgery. By saying we, I mean every surgeon in this room, we can make you worse. It's easy. It is. And still bill you. It's not our goal, but some things, one, if you look at the numbers, if you look at the journal, if you look at everyone that did the research for the last 80 years and says, we tried this, we tried this, we tried this, we tried this, but this is what worked the best and it's not surgery. Boutonniere deformity, you blow the this tendon off of the kind of the base or the back dorsum of the middle phalanx. So now the PIP joint is sort of shooting up through where it wouldn't be able to normally. The lateral bands, which are here, normally there's an equator, and if you're above the equator, you're going to extend, and if you're below the equator, you're going to flex. And normally the lateral bands are down here. So your finger is like this. But if you blow this guy up here, instead of this, you end up with that. And boutonniere is, I don't know, I guess it's something they pinned on people in the 30s or something, a flower. I don't know. Anyway, that's a boutonniere deformity. Almost, I think, two people we had to operate on because they failed treatment. But here's the thing. If you have a boutonniere deformity and you don't see a therapist, and that therapist does not keep your joints supple, I can't do anything. If you come in and everything is stiff, you're looking at me just basically cutting everything to open everything up. Okay? And it didn't have to be that way. If you have nice supple joints, okay, but you've got an extensor tendon here or something is off in one place, we can work with that and your outcome is going to be significantly better. Okay? If you have a radial nerve palsy, if you break your arm and you sever the posterior interosseous nerve or the radial nerve, yeah, I mean, for 6 months you've got to kind of wait to see if that nerve is completely severed, if it's just sort of broken inside, or maybe it's just you bang the hell out of it and it's and it'll recover on its own. But during that 6 months, you need to be in with a therapist doing range of motion exercises, because even if you recover from that nerve injury, what's it matter if every joint from there down is stiff, stuck, and scarred? So great, your nerve works, but nothing else does, but it could. So that's the sad part. Boutonniere deformity treatment, again, splint, motion, range of motion activities. They'll do dorsal blocking splints. There's all these different protocols for all of these injuries. Very specific. The therapists have them. They run them, A to Z, and we see what we get. And if it doesn't work, and if it's not acceptable, it's not going to be perfect. Once you break something, tear something, it's just not the same. You buy a brand new car, you wash it every day. The minute you get that little scratch on it, it's not the same car anymore. You know what I mean? Wrist, bony injuries. All right, broken wrist, Colles. That's what he looks like. Mechanism. You fall, it breaks, Colles fracture. Mechanism. You fell. That's an X-ray. That's the only really good picture so you can see. You get it reduced. Maybe if it's stable, you can cast them. That's overkill, but I guess better a little overkill than not right. Plate and screws, pin and plaster, all depends on stability. Basically, you look at the fracture and you look at it from the side and you think, well, if I push this way, is the bone on the bottom going to be able to stand the load of the bone on top? And if the fracture's like this, and you think about it and you push here and it's all going to slide off the back, it's not stable. You need more than just a cast. Smiths versus Colles, they're broken wrists, just different names. Hamate fracture, playing golf, playing baseball, you take a good whack at the ball. Usually in golf, it's because you missed. You missed and you're in the rough and you swing it's usually more me than Ran. Ran's such a good golfer. And that load, it just stops. That tall grass or that sand trap, that club head stops. Well, all that energy's got to go somewhere. So it goes right up your club head and it just smashes into that hook of the hamate right in the palm of your hand that Dr. Olson showed us on that talk. You saw that hook of bone? What's so funny? He's a friend, I can say that. It's more funny if he's here, though. Someone could text him. Baseball bat, golf club, palm of the hand. So you have this persistent hand pain. It hurts, it always hurts. You get an X-ray, you see the hook of the hamate is off. So what do? Well, you can, one of three things. Let it heal. God forbid you'd have to stop playing sports for a couple days. You can sometimes put a screw in there to fix it, but again, you got to wait, let it heal. Or you can go right in there and you can just take the little hook out. It's just part of where Guillen's canal attaches. You know that. So that's a good picture of it right here. There's the golf club right into the hook, crack. Well, crack of the hook, not the crack. You know what I mean? Anyway, chronic pain. You can have ulnar nerve issues because that's where Guillen's canal is, loss of grip strength. Treatment, we talked about. Rehab. These guys, they all know it. Scaphoid fracture, don't miss this. You miss a scaphoid fracture, guy thinks he has a sprained wrist, and he ends up with a scaphoid fracture. Sometimes it doesn't show up on the initial X-ray. Sometimes they need an MRI. Sometimes they need an X-ray later. Well, they come into the clinic 9 months later, and it's still fractured. It's now a scaphoid non-union. The chances of you fixing it go from 85%, 90% down to 30, 23%. And then salvage procedures after that. It's bad, it's terrible. Scaphoid, snuff box, feel here, tubercle here. Metacarpal fractures. You can get away with a lot of angulation in the metacarpal fracture, boxer's fracture, but if you get it into the joint, you need to get something done. Splint, cast, surgery, all the different ways. Pretty much we do these kinds of things. That's it. Thank you.